Ko Gail Pacheco Tokoingoa. My name is Gail Pacheco. I'm a professor of economics and director of the New Zealand Work Research Institute here at AUT. And my role today is to chair this session. And my first task in terms of chairing is to introduce our speaker. So Penny Mock, she's a principal data scientist at the Social Wellbeing Agency. She's got a lot of research experience in New Zealand government, including roles at the Productivity Commission. That's where I got to know Penny really well from my time there as well, but also at MB and Treasury. Penny has led and contributed to a huge range of projects across government. She's collaborated with a number of different teams and often to extract insights from complex data sets, mainly the IDI. I should also mention her background has got a strong foundation in economics. She got a PhD with a focus on poverty and development economics. And before coming to New Zealand, Penny worked as an economics lecturer at the university in Malaysia. Now with that background of Penny completed, my next task is to hand over to Penny. She's going to talk on vulnerability and multiple disadvantage among older people in New Zealand.
All right. Tēnā koutou katoa, ko Penny Mock Tokoingoa. My name is Penny. I'm actually the principal data scientist in Social Wellbeing Agency. Thank you for the opportunity to present our phase 1 work on older people. So without further ado, I'll introduce you what we have done in our phase 1. Right. So as an introduction to our work, this project responds to and deliver against 2 actions under the cross-government Better Later Life strategy, which focus on older people who experience hardship. The actions are mainly to improve support for socially isolated and vulnerable older people and to address the physical and social determinants of health. So this is a shared action with Ministry of Health. With this broad scope and overlapping between these actions, so we have been working very closely in partnership across MSD, Ministry of Social Development, SWA, Social Wellbeing Agency, and MOH, Ministry of Health. So it is very important, as we all know, hardship cuts across government silos and communities. And a bit of context as well, in this Better Later Life action plan, we also acknowledge that the older population is increasing, and eventually we forecast to hit 1.5 million in 2060. And we also observe the context of societal trends have been shifting. So more and more we have observed home ownership rates for older people is decreasing, and people are living longer, which is actually a good thing. But if they live longer in poor health, which also can increase the stress on health and social care system. And on top of that, based on what we have heard a lot from the communities itself. So due to the cost of living and also COVID-19, recent COVID-19, there are more older people are facing hardship. And this is a phase 1 of the project, and it's mainly to define and to develop measures of vulnerability, multiple disadvantage, and the worst outcome for older people, mainly using the data in the IDI. IDI is actually the integrated data infrastructure. So SWA and some of my colleagues in MOH and MSD, we have very strong knowledge on IDI. So we would like to utilize the IDI to scope and to get a sense of the total number of older people and the size of it and the scale of the people facing vulnerability. And also with IDI, we will be able to understand the characteristics of the affected groups. For example, we can actually have a breakdown of people by different age, sex, ethnicity, and regional level. So this is a rough idea of this key areas for action in a better little life. There are 5 main key areas for action, and then on the other side, the second column actually is the domain. They are the domains, or the well-being domains, as we say. That's where we would like to identify the indicators to measure the vulnerability of the seniors in the key areas for action. So mainly will be the financial domain. So the key is actually to have all the seniors achieving financial security and economic participation. The second, in the health domain, is the key areas for action is to promote healthy aging and improving access to services. And the third, housing domain, is creating diverse housing choices and options. And the fourth is social participations and connection, is to aim to enhance opportunity for participation and social connection. And last but not least is the making environments accessible for seniors. So as you can see, there are the 5 main domains. And for those who have involved in identifying indicators, it's actually quite a tough task to embark on. So how do we decide on what indicators to look at? So first of all, we actually organize a workshop with relevant governments. So of course, it goes without saying, we actually looked at a whole list of the literature review to begin with, and then we engage with multiple agencies to gather all the subject knowledge in this respect. And then we also engage with an expert advisory group. It's mainly comprises of academic and community experts. And they have been really extremely helpful for us to frame and also to check with them that whether it resonates with what they actually observe in the community. And the third, which is a very interesting part, is we have several actually, deep dive sessions with our Minister for Seniors, which is Minister Burrell. And for those who may not know her well, she actually uses IDI in her past academic career. She has a lot of knowledge on IDI. So we actually had a very deep dive session with her. And it's not every day you get a minister who's really interested in IDI and talk about all technical things. So I particularly enjoyed the session with her. And last but not least, MSG has also had a huge program that reached out to the community and engage in engagement kind of a strategy. So to contextualize the data insights and also to verify what we observe in the data, which is actually quite important as well. So this is how the process we have gone through to decide on the indicators. And then eventually we actually came with an approach. So we decided to actually utilize the census 2018 because the housing, for example, the information on the housing is actually predominantly available in census 2018. And with the latest census coming up very soon next year, we can actually use another data point in 2023 census to build that kind of the 5-year kind of a life cycle. So that is what we have decided to do. Of course, we can also look backwards in the census 2013. I'll go to that a bit later. So of course, our study population of residents it will be age 65 and above as at June 2018. And they has to reside in the country for at least 6 months between April 27 and March 2018. And as census mainly captures people living in private dwellings, we also analyze seniors in residential care and hospital using Interact. We will exclude seniors who haven't interacted with government services because that is actually linked in the spine in IDI. Tourists, because if they are here only short term, we will exclude them because they have to be in the country and they are resident at least for 6 months. And because it's actually based on 2018 census, and of course other IDI linked up to the data set, we will not account for impacts of recent events such as COVID-19, Cyclone Gabrielle, and Auckland flooding, and the rising cost of living. But however, we have actually done a separate piece of work that's focused specifically on the seniors with our colleagues in Treasury using their TAWA model to look at the seniors' cost of living, but that will be a separate piece of work, but it will not be presented today. But happy to talk about it if you are interested to see that later. So this will be our measurement of vulnerability in all the 5 domains that I've listed out just now. So I'll go through very briefly on the indicators that we have chose. The first is I will start with my right-hand side. So that will be the housing. So the housing will be more on census, but we are going to look at those who experience poor housing quality and or overcrowding. And financial part, we will actually look at those who received any main, second tier and third tier benefits from MSD, because they are mainly the main benefit, they are income test. And accessibility. So that is mainly looking at census and also driver's license. If the household has no vehicle and driver's license. Social participation, this is quite a tricky one. So we have actually decided to look at the census where if you live alone, a senior living alone and do not have any engagement with the family, whānau, or volunteer in the community. So that's our proxy of social participation. And last but not least is the health. So it will be capturing people or seniors experiencing multiple physical or mental health conditions. Sorry. So this is actually going in detail about where the sources of IDI they come from and what kind of benefit that I've mentioned briefly just now. So I'll go in detail a bit more on the health vulnerability. But before I go there, I might just touch base on how we define financial vulnerability. So a person or a senior experiencing financial vulnerability is where he or she received any MSD income tested benefits. It could be the main benefit, it could be the second tier benefit like accommodation supplement, or the third tier, which is special needs grants, for example. So that's from IR and MSD. And the health vulnerability is where a senior or a person experience 2 or more physical health and or mental health condition. So there are 7, respectively, 7 physical health conditions that we identify, and also 7 mental health conditions that we identify specifically, resulting to the largest utility loss for older people in the global burden disease. So that counts to around about 67% of the utility loss. So give an example of I'll give you an example of what physical conditions it will include. So it could be COPD, chronic obstructive pulmonary disease, dementia, Alzheimer, and so on and so forth. And mental health conditions will be alcohol addiction and other drug addiction, schizophrenia and bipolar, and so on and so forth. So these are the groups of conditions that we looked at, and how we identify them is if they have been any hospitalization or received any medication or being diagnosed for any of these conditions. So we will group them and link them up as yes, they have physical health conditions. And next will be the housing vulnerability. So that is based on census 2018. So we define them by if the senior experiencing poor housing quality and or overcrowding. So poor housing quality is where if a person lives in any of the housing condition where you have sometimes or always have a mold size larger than an A4 paper, always and sometimes damp, the housing condition, or missing at least one basic amenity such as cooking, toilets, and no electricity, and no heating used at all. So if you have any of these conditions or any of this not saying yes to, so we'll classify them as having a poor housing quality. And overcrowding is based on the census. They actually looked at whether you need an extra bedroom or not. So that is actually the definition of overcrowding. So that's based on Census 2018. And the social connection vulnerability is defined by whether if a person is living alone and they have no contact or not helping their family and or not volunteering in the community. So there are indicators that you can observe in GSS that says whether you are lonely. We do actually double check that to see, whether the size actually matches up with what we see and observe in the census. And it is round about the same order of the ballpark, but there are some differences as well that we observe based on the census versus the GSS. And the access vulnerability is defined by if a person has no driver's license and live in a household that does not own a vehicle. So it is a rather, I have to say, of all the indicators, we'll touch base on that one. But some of the indicators that we do struggle to identify, but given that this is the best indicator that we can find in IDI, so we actually use this as it was available in the IDI. So as you can imagine, you're familiar with IDI disclaimer, so I'm going to present the output very soon, so we'll have to see this a little bit. All right. So let's take a look at the size now. So this is just a point in time, because we start with a helicopter view to see, okay, in 2018, how does the vulnerability look like for the older people in New Zealand? So it's good in the way that you look at half the population, which is 367,000, 54% of the total population we observe. They do not have any vulnerability by our definition. But having said that, I will show you the population breakdown later on. We do observe quite a majority of them at the younger cohort, which is around about 65 to 74 years old. As you can imagine, if a person when they age, they will get more kind of vulnerability, or even like not even in one, but multiple domains. So, but it's comforting to see that half the population is actually having no vulnerability. And for the 33% of the population, they have at least one vulnerability. And the remaining 13%, they will have multiple disadvantage, where you have vulnerability in at least two or more, well, two and more domains. And the most is actually from the two domain, vulnerability in the two domain. Let's have a look at the first cut of the one domain. So of our total population, if you add up to all of them, it's around about almost 700,000 people of the older people in 2018. So not surprisingly, 24% of the population actually experiencing health vulnerability, which is around about 170,000 people. And the second largest is actually housing. So housing is actually 18% of the population, or 97,000 people experience housing vulnerability. And then if you go to the third highest, is actually social participation. So at least 17% of the population we observe experience social vulnerability. And of course, the financial is the fourth, and the last is the accessibility, that is 3%. So in total, right, that will be around about 90,400 people are experiencing multiple disadvantage. So you'll be curious to see what they are in single domain first, but we'll go to that in the multiple disadvantage in detail later. So I'll start with the first. It is the health. So for health, of course, it's 24%. That's the same figure that you observe. But out of that, one might be interested to see for the physical and mental, which are the dominant conditions that the older people face. So round about 93,000, so 94,000 people actually faces physical health condition. So multiple physical health conditions, sorry. And round about 69,000 people actually experience a combination of physical and mental health condition. So multiple means is actually two or more. So that is where we classify as vulnerable in the health vulnerability. And interesting enough, we actually observe that older men and women have differences in experiencing of health vulnerability. So men are more likely in the multiple physical conditions, and female, as opposed to female, is more likely to experience combination of physical and mental conditions. What about different ethnicity now? So Māori, we observe Māori older people experience the highest portion, which is 30.2%, and followed by the Pacific peoples and MELAA 28%. So what about social economic deprivation? So we actually quantify social deprivation index by quintile now. Instead of decile, we actually group them by quintile. So, well, it's not a surprise because we actually do observe that seniors living in the socio-economic deprivation areas are experiencing higher vulnerability. And then I'll go through quickly but this is some selected highlights that I actually or some insights that I think it is quite interesting. So for housing, 18% of them actually reported experiencing housing vulnerability, but out of that, poor housing quality alone is actually it dominates. So that 84,528 people represents 87% of the 97,000 people. So it's predominantly poor housing. And overcrowding is around about 7,000, and then poor housing quality and overcrowding it rounds up to 6,000 people experiencing that. So what about financial? Out of the 55,000 people who face financial vulnerability, majority of them actually claim they receive accommodation supplement or the TAS. TAS is temporary additional support. It's actually tier 3 benefits from MSD. So majority of them, they do actually receive that. And special needs grants as around about 7,000 people. So this is what we classify as vulnerable. If a person actually receive multiple MSD benefits, so we actually regroup them and define them as acutely vulnerable. So for example, for those who receive both accommodation supplement and temporary additional support, so there are around about 6,000 people receiving that, and then 4,000 people actually receive special needs grants and accommodation supplement or TAS, which is a temporary additional support. And I'll go on with the accessibility. So in the accessibility, recap a little bit. Accessibility is where hold on. If you do, it's actually defined by if you do not have driver's license and you live in a household that doesn't own a car, a vehicle. So that's the definition of accessibility. So it's not surprising that older cohorts actually experience higher vulnerability by that definition. And then if you cut down by the breakdown by the ethnic group, Asian and MELAA is actually the top two. And last but not least, the social connection is where we cap on how we define if you live alone and you do not engage or help your whānau or volunteer in a community. So it's not surprise again. So the older cohort actually have a higher proportion of them experiencing social vulnerability, and around about 18% European actually experience social vulnerability. Okay, so this is the one that we are going to focus a bit more, because that is where you will see the combination of more than 2 or more domains of vulnerability. So let's start with what we observe as a demographic breakdown first. So we actually noticed that 1 in 4 older Pacific people do experience multiple disadvantage. I'll go in detail what they are later on, but this is just a general highlight by ethnicity first, and followed by Asian, Māori, and MELAA. And the proportion of the older people with any vulnerability does increase with age, and this is not a surprise, but we actually do see that there are quite a high proportion of the older people with more vulnerability in multiple domains actually increases, predominantly the health domain. That's not a surprise as well. By region, so we actually look at the regional breakdown, so that one of the questions that MSc is wanting to see also is to see whether they have any accessibility or any equity in terms of certain regions not accessing certain services and so on and so forth. But this gives you the picture of the total people in the particular region that experience multiple disadvantage. So we identify Auckland, Gisborne, and the West Coast. They have the highest proportion of older people who experience multiple disadvantage. And then if you look at the color of the New Zealand map, the darker color will indicate a higher proportion of older people in that particular area that experience multiple disadvantage. So this is something that we have done and break down by what types of domain they actually have in terms of the multiple disadvantage. So as you can see, older people who experience multiple disadvantage have a huge spectrum of need. So, and each column, okay, before I go any further, let me just explain how to read this graph, because it's actually quite a lot to digest here. But this is quite a cool graph if you understand how to interpret it. So each column corresponds to the column of the dots directly below it. So for example, the first column actually shows the number of seniors experiencing health vulnerability. So that's the figure that you have seen in the previous slides, so 24%, and it actually comes up to 168,000 people. And then if you look at the second orange bar, that talks about 2 vulnerabilities. So most of the older people experience multiple disadvantage in 2 domains are due to health, poor health, and lack of social connection. So that rounds up to 25,000 people, and that represents 4% of the total population. The total population is around about 686,000 people, or rounded to 700,000 people. So that is our denominator of calculating the percentage. So the numbers are not mutually exclusive. In other words, if a person faces health and housing vulnerability, the person will appear 3 times. So in the health single domain, in the housing single domain, and also the combination of health and housing to vulnerability domain. So as you can see, once you go to the end of the tail, so there will be adding more and more complexity now. So the 3 vulnerability and 4 vulnerability and of course 5. So on the 3rd vulnerability, you can see from the graph on the column, most of those people experience 3 domains, vulnerability in 3 domains due to poor health, housing, and financial constraint or financial vulnerability. So this actually sums up the whole dimension of what types of multiple disadvantaged person face when actually in our population that we observed. Right. So this is something quite fun that I wanted to try. I haven't tried it to other people, so you'll be the first to look at it. Oh no, my colleague actually did try to with other people, so you might be the second one. All right. So part of our as SWA, we actually do want to support the community using the data that we have collected, or even engaging with people, and other people can utilize the data that we have produced. And while we were talking to lots of our stakeholders, they asked a lot of very specific questions they're interested in. So we did publish our paper, but we actually are quite selective of the insights we find it interesting and useful, but not necessary to others. So we thought that it might be interesting to just produce a dashboard so that based on what we have done in this first phase, so that people can actually go into it and have a play of how they want to look at their particular population of interest, and to see where they are and how many of them actually having this facing this disadvantage or vulnerability. So let's try. Okay. Right, worked. Cool. All right. So of course we have to have the IDI disclaimer. So we haven't published this dashboard yet because we will like to inform our minister, and then once she's informed, we will publish this probably either in this year, which is this week or next week, or next year. So I'm happy to send the link. One is actually published so that you can actually play around as well. So this is how it looks like. Right. So if you look at the tab on the top, so this gives you an overview of the population of the seniors that I've just mentioned. So we have around about 700,000 people of older people that we identify, and these are all. It actually cuts by the population of disability, ethnic group, age, sex, socioeconomic deprivation quintiles, rural area, and also obviously regional too. So of course you can actually choose, for example, to slice and dice according to the particular group that you're interested in. So you can say, for example, I'm interested in Māori, and I wanted to know the population size and the disability indicator that we identify. If you're interested, I can explain a little bit more, but I'll just park this aside first on the disability indicator that we have derived from the IDI. So this is the total overview of the population, and then you can go into the domains now. So this is just a single domain. So that is, to start with, is the health domain. So these are the figures that you are quite familiar. You have seen that in the first few slides, and obviously it's the same graph that you actually observe too, but you're obviously able to slice into different groups of particular interest that you're interested in. And then same goes, you can actually look at the housing and finance, accessibility, and social. So, and then we'll go to the multiple disadvantage. So this gives you also the overview of the total number of people reported experiencing multiple disadvantage. Recap, it is actually 2 or more domain. So a person actually facing vulnerability in 2 or more domains. So that the total is around about 90,000 people. And you can actually see the breakdown of the demographic and where they live in the region as well. And then the combination. So this is actually the combination where you can see what kind of combination of, let's say, health and social, health and housing, and the magnitude or the size of it in maybe the 2 domain, 3 or 4. But unfortunately, because of the size itself, we are not able to cut it by region. So you won't actually be able to see a region here, but you are able to see the breakdown of the types of combination of the vulnerability in this tab. So I hope that this gives you an interesting insight of what we have done, and then feel free to play around with it. So cool. And that's it, I think, today. Thank you all for your kind attention. So I open the floor for any questions if you have anything to ask. Thank you.
Well, thank you, Penny. Yeah, that was really interesting. I really like the dashboard at the end. It's always good to have visualizations of research, and particularly work by economists. I think that's a really useful tool that economists should use more often. So in terms of the social connection domain that you're looking at, so that kind of looks at the 2 elements there was the sort of the negative side, the deficit side of thinking about social connection, right? Had you considered thinking about the positive side as to see, for instance, you were looking at if they volunteered, but what about if they were employed, as a way of understanding if they were in social situations in that space, and that might be the positive side to see that they are in a range of social interactions. And yeah, did you think about that space?
Thanks, Gail, because we have a lot of debates about this, because I think of all, I have to be honest, of all the indicators, right, I have to say that this might not be the strongest of all, the social and accessibility part of it. So some actually from our expert advisory group, they've actually raised the issue about a lot of people needing to work because they have no choice to work. So that is the narrative that we often hear in terms of, okay, when they are working, most of them, they need to work because they can't afford to pay for their mortgage, they can't afford to pay for the rent. So in our data set, it's very hard to disentangle why you actually work. So it is a proxy. It is actually kind of nice proxy to have, because it will be the whole of the population that we can see, rather than any like GSS where you are lonely and the kind of stuff. Is actually a survey based. So yeah, we have a lot of discussion about that, but I think we were trying to identify whether is there any other kind of a social participation or connection that we can actually use to identify them, that okay, you are socially active and stuff like that. So yeah, I hope that I've answered your question.
Yes, I think it might be something that, might evolve in the future as well, because I think at the moment there are obviously many people who work after that age because they have to, but that is definitely changing over time. And given the rising participation rate in the labor market.
Yep. Thank you.
Well, thank you.
Thank you. That was very interesting. Can you explain a little bit more the financial vulnerability measure? I don't know the benefit system that well, but I know that you have the superannuation above 65. And can you actually get the superannuation at the same time and also have means tested benefits, or is this the 8% that you have? Is this the share who are eligible for superannuation?
That's right. That's right. So most of them do receive super. That's a good question, actually. Thanks, Thomas. From what we observe, most of them do get super, but there are some people who do not receive super for lots of reasons because of the resident criteria. So you have to be in the country for the X amount of years. I think 10 years. The new policy is 20 years, but you have to have the condition fulfilled in order to be able to receive New Zealand super. So we didn't dwell into a lot of that because we did actually ask our MSD colleagues as well about whether it is possible or not of people who are not receiving. They said yes, it is possible not receiving it because if they are not in the country for they are not eligible basically. So that is highly possible. So if you receive super, you are also eligible for tier 3 benefits. For example, temporary additional support and also special needs grants. That is actually one of benefit. So if you actually face difficulty buying food, you can actually apply for special needs grants just to buy food. Is actually one-off. They will pay you one-off. And then if you have difficulty housing, you can't pay your rent, right? You can also apply for special needs grants for housing, specifically for housing. So that is the tier 3, is just one-off payment.
Cool, thank you.
There's a question in the chat around whether you've compared the results with the 1974 special survey of deprivation of people 65 and over that was done by MSD, which sounds like it was a very specific survey. And they found that the example that the form of house tenure was a critical discriminator with health and transport next. This is from Len Koch.
Right. Did you mention it is 1974?
Yes.
Oh, okay. Oh, wow. Okay. I have not seen. I can ask my colleagues in MSD to identify it, but no, we haven't actually seen it. But we did actually look a lot at Brian Perry's work on material hardship, material well-being hardship. That is specifically looking at HES. And also compare our kind of it's hard to reconcile, to be really honest, but we try to sort of make sure that it's not way way out of the ballpark. But okay, we will thank you for that. We will actually I'll actually look at the report then. It's always good to look at what others have done in the past. Thank you.
Oh. And I think there's a hand up from Waylon, so you might want to, do you want to ask a live question, Waylon?
Yep. So I have 2 questions. First one is about the age range. So you started with the age above 65, but I think all of the measures all of the definitions, based on the definitions, you can plot the the share of people who are vulnerable across all ages. So I was wondering if you have tried to plot it, say, from age 45 or 50 onwards, and then see if 65 is actually a meaningful age or not in terms of experiencing more vulnerability. So that's first. And second one is, I kind of am curious about what the definition of the social vulnerability wanted to get at. Would part of it be trying to say that a lack of social connections might lead to, say, mental health or something like that? And if that's the case, have you tried to see even a basic sanity check that social vulnerability is actually positively correlated with your mental health outcomes?
Cool. Yep. Okay, the first question, which we gather it both very good questions, because we actually talk to a lot of people, as you can see. One of the feedback, the main critical feedback that we got from the expert group was different ethnic group, they have different life expectancy. So some will actually do not live that long. So ideally, a person at 50, it is equivalent to maybe someone at 65 years old with different ethnic breakdown. So one of the things that we are doing now, well, MSD is actually mainly doing it, is to look at people aged 50 and above rather than 65. So we actually look at 50 people 50 now, and as a kind of a comparing, the same kind of vulnerability for different ethnic groups specifically. So that is something that we are looking into it. And we have actually the second phase actually does look at the younger cohort to see whether is there anything that we can see a trend of going into vulnerability at the age of older, 65 and above. So that is something that MSD is mainly doing that. So they are looking into that now. In terms of the correlation, we have a lot. We have done quite a bit, but I did not actually publish it, or I did not even take it up because there's so many gazillion correlation combination that you can really think about. So from memory, I can't remember though, but yeah, don't quote me on that. But I do kind of vaguely recall that, I'm not quite sure it's whether mental or physical, but
Yeah.
yeah.
Let me add a little bit of context to that question. I was mainly concerned about living alone, because I would guess that part of being able to live alone is that their economic situations is probably better.
Yeah.
And that also probably is reflected on your ethnicity breakdown. So I obviously do not know much about how the data looks like, but yeah, it's just that being able to live alone would be a big contribution to people being, included in that. And a lot of times, maybe that is not really, connected to social vulnerability, but I'm not sure.
Yeah, it could be because we just get a proxy to see, okay, whether social connection is that an issue or not. But a lot of people are happy living on their own. So I guess that's not really a big issue for a lot of people, but I guess that is just a proxy to see whether you feel lonely, that kind of stuff. So it is not exactly identical to the question whether are you lonely, like GSS will ask the questions on that one. So I think that's something similar, but that's the closest proxy that we can actually find. So hence that's our kind of a crude cut of this as well. And possibly I should also mention about overcrowding. So one of the feedback that we mentioned, we were actually given as well, was overcrowding definition is actually based in the Canadian kind of definition. So where on a general, there will be maximum of 2 person in a bedroom. And of course, there are certain conditions imposed on it, whether you are of a certain sex and certain age that you can or cannot share a bedroom. So that is actually quite a Eurocentric view in that. So one of the main feedback that we obtained from the expert advisory group was a lot of multi-generation population in certain ethnic group, they do live in the household. So you could have grandparents, parents, and grandchildren living in one big house. So with that definition, we kind of not really answering that particular cultural issue that we're actually trying to identify. So it's actually quite a lot of work that we need to think about whether it will be suitable measurement or whether it is actually good enough now, because there's no other measurements that we have. So there are things that we have to be cautious about oversimplifying the indicator to represent the whole of the older population.